Hello and welcome to our presentation looking at a matched analysis of the impact having a carer has on an individual's health and social care utilisation across 5 settings of care for adult residents of Barking and Dagenham. My name's Jenny Shand and I work at UCL Partners and I'm a researcher at UCL. And this shares some work that I did in collaboration with Professor Steve Morris at the University of Cambridge and Dr. Manuel Gomes at UCL. Globally, an increasing number of people with long-term conditions and social care issues are managed at home with the support from carers. And it seems that reliance on carers is increasing, with reductions in council budgets resulting in fewer people getting access to formal support, alongside the general reality of an ageing population, with more people in the population needing more intense care and services. Across the UK today, an estimated 6.8 million people are unpaid carers. That's 1 in 8 adults, and they're often described as lay or informal or family carers. But what we're talking about in this research piece is anyone who offers unpaid care support to the care recipient. And each year you may have seen the figure that people share around. Each year it's thought that carers save the UK economy £132 billion. This is calculated using national survey data on the number of carers, the number of hours those carers are providing, and estimates of unit cost of replacement home care. So the £132 billion assumes care substitution. By having a carer, people require fewer hours of paid home care, or rather, the carer contributions are a direct substitute for paid home care. The NHS in England has a policy commitment to improve identification of carers and strengthen support for them in recognition of the impact being a carer can have on a carer's health and wanting them to maintain this caregiving role. However, the literature is mixed on whether carers do provide care substitution and reduce service utilisation for the care recipient. Others suggest having a carer could increase utilisation as they have an advocate who can facilitate access to services, transport them to appointments, or overcome denial that more care is needed. Our research sought to understand whether people with a carer have different levels of service use across 5 settings of care when compared to those who do not have a carer but have matched individual characteristics. The 5 settings of care we were looking at were hospital, primary care, community services, mental health and social care. We were working with an individual level linked dataset in Barking and Dagenham that gave us access to information about individual level service use across these different settings, alongside wider characteristics and variables about the individuals themselves. From this linked dataset, we extracted adult residents of Barking and Dagenham between the 1st of April 2016 and the 31st of March 2017 as our base cohort. We then excluded those who died in year, and that was because both they wouldn't have had 12 months of activity, but also the known associations between increased health and social care service use and your last year of life. We removed those who had moved out of the borough within the year, and that's again because they didn't have 12 months of service use. We removed those who were a carer, and that's because of the impact of being a carer on their own health needs could be complicated by the known associations between being a carer and declined health status. So if we had included those in the dataset, it would make it possible for them to be in the matched controls, which could impact the interpretation of our results. We also removed those who lived in households of more than 11 people, and that was because we felt that the assumption was that those living in a household occupancy of more than 11 could be in a care home setting, and therefore they were excluded from both the treatment and the control group. And within that group there were 33 individuals who had a carer. So the remaining cohort was 112,316 adults who were confirmed residents of Barking and Dagenham and for whom we had 12 months of data from the 1st of April 2016 to the 31st of March 2017, of which 1,295 were documented in their primary care records as having a carer. People with a carer can differ in many respects from those who do not. For example, those with a carer tend to be older, they have greater degrees of morbidity, such that the mean costs of the two groups, those with a carer and those without, are not directly comparable. So in this slide you can see that the mean costs in our cohort dataset of those that have a carer was £12,680 for the 12 months across all 5 settings of care, and for those that do not have a carer was £1,415. These two groups are not directly comparable, and therefore we sought to create two comparable groups that were identical with respect to all observed characteristics except the exposure to a carer. We used nearest neighbour matching to create our matched case control cohort, and we matched across characteristics of the individuals, their age, which we categorised into 5 different age bands: age 19 to 49, age 50 to 64, 65 to 74, 75 to 85, and 85 and above, their gender and ethnicity, and then their health and health risks, so the BMI category, smoking status, the number of and the prevalence of 16 conditions. We looked at both the conditions themselves and the aggregate number of long-term condition count. And then we looked at some household factors, housing tenure, whether or not the individual was in receipt of benefits. This may be pension, unemployment benefits, job seekers allowance. We looked at housing occupancy, and we also looked at the deprivation of the ward that the individual lived in. And that created a matched cohort of those that had a carer, which was 1,295 people, with a matched control across these different variables for those that did not have a carer. Again, 1,295 people. After matching, the similarities between the group of individuals that had a carer compared to those without a carer improved across all variables. And you can see here on the slide that the standardised differences were brought within the threshold for meaningful balance. So the empty circles are the full cohort and the coloured circles are the matched cohort. There were 2 exceptions, namely for age and for ethnic group, which was borderline at 11. So we did some specific robustness checks for these different pieces. It's also worth noting that most of these are categorical variables, whereas age, when we were looking at the standardised differences, we were looking at it as a numerical variable. So the reality is that when matching on age in 5 different categories, it came into an exact match. We calculated the average treatment effect, looking at the impact having a carer had on cost-weighted utilisation across 5 settings of care. We found that having a carer was associated with a 27% increased cost. This was a mean difference of £2,662. The increase was found across all care settings, but the majority of that increase came from social care, which accounted for 39% of the difference. There are several strengths and limitations to note. So firstly, a strength of the study was including these 5 settings of care, in particular community services, mental health and social care. To date, in the literature, primary and hospital care dominate analysis of service use, and that's partly due to the availability of good quality data in those 2 settings. So including all 5 settings of care allowed us to have a broader picture of the impact of carers on health and social care costs compared to previous studies. By using matching, we've sought to minimise any differences in observed confounders between the individuals with and the individuals without a carer. And in addition, unlike regression modelling, these matching approaches are expected to provide more robust estimates about the effect of carers on health and social care costs. There are several limitations to note. We identified people who had carers from the primary care records. This is likely to underestimate the number of people with a carer. So in our population, in our cohort data, we had less than 1% of the population were registered as being carers. However, looking at census data in Barking and Dagenham, the true prevalence is expected to be nearer 8.7 to 10%. And one of the reasons for the low levels of carers identified through primary care is the uncertainty around the definition of the term carer. There is extensive literature that shows that many carers do not identify themselves as a carer and are protective of the relationships with the person they care for. The risk to our analysis of this, of the low carer numbers, is that the exposed cases may contain people who have carers that are not formally registered with primary care, misrepresenting them as controls. If that was the case, you would expect, therefore, based on our findings, that you may see a wider difference between those with a carer and those without. We also didn't have any information on other forms of privately paid care or voluntary services. However, it's likely to be low in Barking and Dagenham because the borough is very deprived and the average earnings per household is very low, so we wouldn't expect there to be high levels of privately paid care. We were also unable to adjust for levels of caring, so either the tasks that were being completed or the hours that were being provided. But while we have not identified any major factors that could be an important predictor of health and social care costs because we were matching across an extensive range of variables, there may still be unobserved confounding. So what are the implications? Firstly, care substitution. In much of the UK, the discourse on the role of carers rests on that economic assumption from the equation we shared at the beginning of this presentation, that carers are a substitute for formal care. Now, the findings of this research suggest that that's not necessarily the case, or rather that the additional service use induced by the carer may dominate any substitution effect. Secondly, carer education. There is an opportunity to reflect on the relationship between carers and the formal care system and identify interventions that could support more care substitution. Now, this may include providing bespoke training and education and seeing carers as an extension of the care workforce, in a similar way that we as the NHS have been investing explicitly in patient education for the last 25 years. The same logic could be applied to carer education, namely they spend more time with the care recipient than the care recipient spends with health and social care services. And finally, health inequalities. The findings of this work suggest that people without carers may be experiencing inequitable access to services, and this needs to be investigated further. Thank you for listening to our presentation and for showing an interest in the research that we've conducted. If you have any questions, please do comment below the video or alternatively email me at jenny.shand@uclpartners.com. Many thanks.